Israeli, an organic chemist and professor. It's a pleasure and an honor to have you, Professor Raphael Mechoulam, in the first Digital Medical Cannabis Congress. Usually, the professor doesn't demand any kind of presentation, but since we are having doctors and professionals that are beginning their journeys into cannabis, I must say that Professor Mechoulam is Israeli, an organic chemist and professor of medicinal chemistry at the Hebrew University of Jerusalem in Israel. Mechoulam is best known for his work in the isolation, structure elucidation, and total synthesis of delta-9 tetrahydrocannabinol and cannabidiol, most known as THC and CBD accordingly, and for the isolation and the identification of endocannabinoid system. So I welcome you, Professor, and give you the word for your lecture.
Thank you. It is a pleasure to talk to your audience. I've had strong ties with South American scientists and clinicians. We have worked together for many, many years, almost 45 years, and we have published together both on the basic scientific aspects as well as on clinical studies. I would like to present an overall picture of cannabinoid science, which will include not chemistry really, but mostly the biochemical aspects and some clinical aspects. Whenever people talk about cannabis, usually they think about the plant, the cannabis plant, which produces the cannabinoids and which is being used as a recreational plant as well as for medical whatever medical uses have been found over the last 30 or 40 years. But this is just part of the picture. As a matter of fact, cannabinoid science is much wider. So I will try in a 10, 15 minutes talk to present a much larger picture, a picture of the cannabinoid field as I see it. Well, let's start, of course, with the plant. The plant, the cannabis plant, has been used for 2,000-3,000 years. We have data from China, but of course it has been used also in the Middle East. It has been used in India for, as I said, maybe a couple of thousand years. It didn't reach Europe to any major extent, or America, South America, or North America, until much later. But the use in the East was wide, and it was used both as a recreational drug and as a medicinal agent. Actually, cannabis came to Europe to a large extent when soldiers of Napoleon were in Egypt, and they found that, yes, a lot of the population was using it as a recreational drug mostly, not as a therapeutic drug, and they brought it to Europe, and it became part of the literary group. In France, for example, there was a Club de l'Assassin, and some of the major literary people in France in the 19th century were involved. But slowly, scientists, medical people realized that it is a medicinal agent, and it was used to a large extent in Europe in the 19th century, early 20th century. Then it went down. The use essentially disappeared as a medical agent because most drugs during the 20th century are used as well-defined drugs, drugs that can be measured, that can be weighed, that people will know exactly what they get. This was not possible with cannabis because the active compounds had not been isolated in pure form, and therefore it was not possible to know exactly what is being administered. There was some work in Europe and in the US, the 1930s, early 1940s, but then the whole research field essentially disappeared because it was illegal to work with to use it, and therefore very difficult to do research. We started working on cannabinoids in the 1960s. And I was surprised to see, the contrary that to morphine, which was isolated from opium, and cocaine, which was used from, was well known in the 19th century, the cannabinoid chemistry was not known. And if we don't know exact chemistry, very difficult to go ahead and use the cannabis as a drug. So in the 1960s, we isolated quite a lot of compounds from cannabis, including the only compound that showed psychoactivity, tetrahydrocannabinol, THC. We elucidated its structure and later synthesized it, and the same for cannabidiol. And these compounds were then investigated to a very, very large extent. And a lot is known today about these two compounds. As a matter of fact, THC has been approved as a drug. CBD has been approved as an anti-epileptic drug. And there has been, over the last 10, 20 years, quite a lot of work on that. THC is mostly used as a drug to lower the vomiting and nausea in patients that receive chemotherapy. And quite a lot of chemotherapeutic drugs cause nausea and vomiting. But it is a relatively small field, and it is not a major drug. Cannabidiol, CBD, by contrast, is not psychoactive. It does not cause the psychoactivity known with cannabis, and therefore it is widely used, although it is not approved by any government except for epilepsy. It has not been approved for many of the other effects that we know that exists. And this is a pity, because it is, as I said, non-toxic, does not cause side effects, and has a lot of positive effects. For example, it lowers anxiety. And this is one of the reasons why people take it, because people that are in stress, loaded cannabidiol lowers the stress. Cannabidiol is an excellent drug in several autoimmune diseases, rheumatoid arthritis, for example. It is an excellent drug for diabetes type 1. But unfortunately, these have not been investigated in humans. The only aspect, the only cannabidiol has been approved in the US only for pediatric epilepsy, for certain types of pediatric epilepsy. This is really sorry that this is the situation, because it can be used as a drug much better. But in the US, at least, it is widely used as an extract. And I've been told that the cannabidiol, CBD, is being sold to the extent of $2 billion a year in not only as a drug, but also in whatever people can use. It can be sold in drinks. It can be sold in any other food. This is not the way to do it. I mean, a drug should be given in exact amounts and should be backed by good clinical investigations. And we don't have that. This is, again, something that has to be done. I mentioned epilepsy. This is a research project with pure cannabidiol that we did with a group in Sao Paulo, and this was published 40 years ago. And we showed that it is an excellent anti-epileptic agent. But we were disappointed to see that nothing happened. It was not approved at that time. It took another 35 years until cannabidiol was approved as an anti-epileptic agent, and now it is sold as a drug in the US and in many other countries. Why did we have to wait for so long? We could have helped, the drug could have helped thousands of children that have a pediatric epilepsy. Well, but this is the situation. We have the same situation today with many other uses of cannabidiol. For example, as I mentioned, diabetes type 1. There are no clinical trials. Schizophrenia, high doses of cannabidiol have been shown by an excellent group in Germany that that cannabidiol, pure cannabidiol, is a good anti-schizophrenic agent. Yet nothing has happened. Maybe, just maybe, we could help many patients with pure cannabidiol. Now, let us go back to the plant. The plant does not produce cannabidiol and THC. The plant produces compounds that are precursors. These are the cannabidiol acid, CBD acid, and THC acid. These are the compounds that the plant produces. These compounds are not stable, and they slowly convert into CBD and THC. So these compounds that were the real natural products have not been investigated thoroughly because they are not stable. So a few years ago, we managed to stabilize chemically, and I will not go into details. We managed to stabilize CBD acid, make it a stable compound, and we tested it. And it turned out that it is an excellent compound by itself, excellent in terms of a drug. It lowers anxiety. It is a very, very potent compound against pain. And so chances are that this compound will become a drug within the next 5 or 10 years or maybe more. So here we have the acids in their stable form, which are very potent. We have CBD and THC, which are very interesting compounds with a lot of possible activity. Now, this is only one part of the cannabinoid story. For many years, it was not known how THC works, what's the mechanism. People knew about metabolism, people knew about how it acts in different animals, people knew a lot about both CBD and THC, but not the mechanism of THC. Then slowly information started coming in showing that maybe there is a receptor for THC in the brain, in the body. And indeed, in the 1980s, about so many years ago, it was found that there is a receptor, a specific receptor for THC in the brain and later in the body. Now we know that there are two receptors. So, but receptors we don't have because there is a plant. Receptors we have in our body, animals have in their bodies, because we produce compounds that activate or block these receptors, and this is the way they work. So we went ahead looking for compounds in the body that activate these receptors. As I said, the receptors don't exist because there is a plant out there. They exist because we produce compounds that will activate these receptors. This is something very general. And indeed, after several years of work, we found two compounds. The first one we called anandamide, a compound which is present usually in very low amounts in the body, but when needed, like for example, when we are in pain, the body starts producing anandamide. Where we are anxious, the body starts producing anandamide. The anandamide binds to the receptor, and then the body feels the effects of anandamide. So in many respects, THC mimics the natural product, mimics the body, the compound that we produce, anandamide, and there is another one, 2-AG, both. They're a little bit different, but they do the same. THC actually mimics these two compounds. They are not fully parallel to THC. THC stays in the body for a couple of hours, and therefore there are many side effects. Anandamide is made by the body when and where needed. Let's say there is pain, it is produced, it acts on the pain, and the body breaks it down. And it turned out that anandamide is part of a major new biological system. This is a system which consists of the receptor, that I mentioned, anandamide, and the enzymes that break down anandamide or synthesize anandamide. So this has turned out to be an extremely important new biochemical system, and scientists at NIH in Washington have shown and have published that the anandamide system, the endogenous cannabinoid system, is apparently involved in almost all human diseases. This is not something that we can say about anything else, not about dopamine, not about serotonin. It is a very, very central biochemical mechanism, and people are working on this biochemical system. The publication we had on anandamide has been cited many thousands of times because of its involvement in a new system, which will obviously lead to a new drugs. So this is the second phase of cannabinoid research. The first phase is the plant cannabinoids. The second phase is anandamide and the compounds and the system around anandamide, the receptors, anandamide, the enzymes. Now, but we are now in the third phase of cannabinoid research. See, anandamide from a chemical point of view is not a very complicated compound. It is a fatty acid bound to an amino acid. And we have in the body about 20 fatty acids, about 20 amino acids, and the body knows how to put them together. And it does. In the body, we, animals, have about 100 compounds which are closely related to anandamide. Very few of them are cannabinoids, but all those that we and many others have investigated show that they are of very basic importance to our body. We have shown, for example, that one compound lowers the damage. If somebody has a brain damage, a compound is produced very closely related to anandamide, very closely related to the endocannabinoid system, which lowers brain damage. Another compound, which we discovered after quite a long time, quite a few years of work, which is produced by the bones. See, after the age of 50 or 60, men and women should get osteoporosis. The bones are not built as fast as they are destroyed, and this brings osteoporosis. Now, we found that the body produces a compound, an anandamide type compound, which tries to lower the damage of osteoporosis. A very important compound, and a company is now developing it. Again, it is an anandamide-like compound. So I'm speaking now of the third phase. The first was the plant, the second one, anandamide, and now I'm speaking of the third phase, which may turn out to be the most important one, because here we have almost 100 compounds which seem to be of activity. And let me complete with another compound, which is produced by the body, and it has to do with addiction. We believe that addiction is a disease, and our body usually tries to fight disease states. So we try to find out how our body, animal body, fights addiction. And we started with nicotine addiction. And after quite a lot of work, we found that the brain produces a compound, an anandamide-like compound, not a very complicated one, which tries to block nicotine addiction. This is probably one of the reasons why people that smoke, some of them get addicted, but others don't. And something else. When somebody stops smoking nicotine, then he's in a bad shape, and people don't want to get near him because he's start shouting, is not very happy with it, we found that this compound blocks the withdrawal effects of addiction. Does that work in morphine, opiate addiction? It does not block opiate addiction. Apparently, our body has a specific compound that blocks opiate addiction. But this compound, which we found to be an anti-addiction, an anti-withdrawal compound for nicotine, also is an anti-withdrawal compound for opiates. So, a company is developing the compound to see whether it can block withdrawal symptoms of opiate addiction. So what I've tried to show is that the cannabinoid system has actually 3 phases. The plant, THC, CBD, the acids, and so on. Then the endogenous cannabinoids, anandamide and its activity, very central in our biology, and anandamide-like compounds, which seem to be involved in a large number of biochemical processes. So I expect that over the next few years, maybe the next decades, we shall know a lot more about the physiology of our compounds, of our system, based on the endocannabinoid system, and chances are that we shall have quite a few drugs based on the cannabinoid system. And I hope that many of you, especially the younger ones, will see that happen.
Thank you very much, Professor. It is such a lesson, and well, it is great to see that cannabis is finally gaining momentum, right, after so many years of the first discoveries. And it is also amazing to see that you keep on the vanguard of the new discoveries, even now that we have so many scientists and companies involved with cannabis. I have a few questions. What is the main advice you would give to a doctor or scientist who is starting a journey into medical cannabis now?
Well, first of all, cannabidiol will probably become a major drug because it has no side effects, has no toxicity, and it has quite a lot of very positive activity. So chances are it will become a major drug. It's already being used in the US as a drug, not always with enough clinical trials behind it, but this, I hope, will change. Quite possibly the precursors of cannabidiol, namely the cannabidiolic acid, in its stable form, it may become a drug because it has a lot of activities. So we shall have these natural products. Chances are that companies, pharmaceutical companies, will also synthesize derivatives, which are more potent, perhaps, than cannabidiol. This has happened with essentially all drugs. You cannot buy penicillin at a drugstore. You can buy a derivative of penicillin. You cannot buy cortisone in a drug. You can buy a derivative of cortisone, prednisone, for example. So chances are that we shall see development of the natural products as well as compounds that are derived from the natural products. And possibly we shall see derivatives of anandamide and many of the compounds that are like anandamide. These compounds are not very stable, so chances are that pharmaceutical companies will try to develop stable anandamide derivatives and stable derivatives for the other effects that I showed.
Great. And you have recently announced a new discovery. Tell us more about EPM 301 and what it can do.
Well, 301 is a derivative of cannabidiol acid, as I mentioned before. It is, as I said before, cannabidiolic acid is not stable, breaks down, and therefore not much work was done on it. Very difficult to work, to do research on a compound that breaks down. You never know whether the breakdown compounds are the active ones or whether the compound is still there and what are the amounts. Now that we have been able to stabilize it, we have shown, we, in this case, is an interesting we. It is 4 groups, we close friends, at one of the meetings, we sat down together, drank a lot of coffee together, and decided to work. And so here we have from several groups, 301, which is a derivative of cannabidiolic acid, and it has been shown to be an anti-anxiety drug. It has been shown to be very potent chemically, and it has quite a lot of other activities. So chances are that it will become a drug as it is, or maybe derivatives of 301.
I see. And as far as I understand, 301 is synthetic, and this subject can be very controversial in the cannabis environment. How safe is it? Is it ready to be applied or to be a base material for final products? And does it perform the entourage effect?
Well, cannabinoids, except for the effects of THC, most of them, including 301, are not toxic. They cause no side effects in animals. We don't have enough long-term toxicity yet, but these compounds have not turned out to be toxic. So chances are that 301, it is not toxic in the short term, but it will turn out not to be toxic also when given to animals for many months. It seems so from preliminary data. So I believe that here we have a very promising field because these compounds do not cause side effects. And therefore, as I said, I strongly believe that we shall see drugs based on these particular compounds.
That is very great to know. Well, you talk to us about the past, the present, and the future you foresee for medical cannabis. So I thank you again for your lecture, for your time, and for sharing your knowledge with us. Thank you, Professor.
You're most welcome, and I hope that the meeting will be a very successful one.
Thank
Bye-bye.
you. Bye-bye.